Hi, everyone, and welcome to today's session. My name is Jeff Freeman, and I'm a Senior Vice President here at CompHealth. I'm excited to be hosting today's webinar in which you'll learn just how easy it is to practice medicine across the country through the Interstate Medical Licensure Compact. Here to tell you more about the compact is Dr. John Thomas, the most recent chair of the IMLC. Good afternoon, Dr. Thomas. How are you?
I'm doing well, Jeff. Thanks. How are you?
I'm doing great, thanks. Thanks again for spending some time with us today. Before I turn it over to Dr. Thomas, I'd like to tell you a little bit about him. He is a board-certified otolaryngologist who has always had an interest in organized medicine and healthcare delivery. He received his MBA in Medical Group Management from St. Thomas University in 2001, has served on the Minnesota Board of Medical Practice for over 15 years, has held multiple leadership positions on both local, state, and national levels in medical regulation, all to make a difference in organized medicine and healthcare delivery. Our licensing team here at CompHealth has gotten to know Dr. Thomas quite well over the past year as this compact has come to life. So we're excited to team up with him today to share the benefits of the compact with you. With that being said, let's turn it over to Dr. Thomas.
So thank you so much for having me. I appreciate the opportunity to talk about the compact. It's something that I've been intimately involved with in the last 5 or 6 years, and always glad to share the experience. So I like to start all my talks with the fundamental reason why we do what we do on state medical boards, and that's the 10th Amendment. The 10th Amendment is probably the shortest amendment, and I like to start off every talk this way because it really sets up the stage for why medical boards exist and why this relationship between state medical boards and physicians and patients are structured in the way they are. So the 10th Amendment, the powers not delegated to the United States by the Constitution nor prohibited by it to the states are reserved to the states respectively or to the people. This amendment, when it was first discussed, caused a lot of debate because it seems obvious. A lot of founding fathers felt that there was no reason to state this, but some founding fathers felt it very important to say that states and the people were fundamentally in charge, and unless something was explicitly given to the federal government, the states would control it. And so the states, this is why we have the state medical boards. The state protects the health, welfare, and safety of the citizens, and therefore the state medical boards, again, protects the patients, and protects the citizens of the state. And so this is a traditional relationship that we've all have known. The physician applies to the state. The state grants the physician a license. The license is a privilege to practice. It's not a right. I've had many encounters at the medical board where physicians told me it was their right to practice, and I have to remind them that no, the state grants the physician the privilege to practice. And then the state interacts with the physician, but if there's a problem, the patient then goes to the state for redress or for complaints. So this is the system in a nutshell. And the 97% is in relationship to the number of physicians who fall into this category. The vast majority of physicians only need one license. Traditionally, physicians would get one license, find a practice, stay in that practice their entire career in that one community, and that was it. And so the medical licensing system was designed around a physician practicing in one location for their entire career. Well, as we know today, things are much more complicated. We've got 3% of physicians who require 3 or more licenses. And so what we're seeing more and more and more are physicians are needing multiple licenses because of increasing mobility of physicians, because of telemedicine, and for just the nature of practice today. So unfortunately, the one physician, one license model hasn't worked out very well in today's climate. And so there really hasn't been any innovation in licensing for literally about 100 years. The last time we talked about innovation in licensing was reciprocity, and that was back around 1912. And we see how far that went because reciprocity never happened. States generally want to do their own vetting of a physician and don't want to rely on the vetting of another state for the qualifications of a physician. So the idea of reciprocity for states really never took off. And so back around 2012, we were hearing rumblings at the federal level about the problems with licensing. we had lots of telemedicine infrastructure companies claiming that licensing was a barrier to the promulgation of telemedicine. And so there was a general sort of critique of medical boards. And I also joined that critique. I mean, I felt that medical boards take a while to license patients, to license physicians. And in some cases, it could be several months. And that several months downtime waiting for a license can result in loss of productivity, loss of patient care, loss of access. So anything we could do to improve the mobility and the ease with which a physician could obtain a license would be helpful. Now, a lot of states address this by simply speeding up their licensing process, trying to decrease their wait times from several months to, in some cases, several weeks. But this wasn't uniform. This was spotty. And again, not all states got on board with the idea of an expedited process for licensing. So around January of 2013, the Federation of State Medical Board convened a meeting to discuss ways of speeding up the licensing process. While we knew that reciprocity was off the table, we knew that we had to come up with something to try to address some of the valid criticisms of the licensing process. So that conversation began around a little bit before around January 2013. And between January 2013 and April 2017, we've had lots of meetings, conversations, work groups, committees, and we ended up drafting what ended up being compact legislation. Now, just a brief discussion of the compact. A compact is simply an agreement or a treaty or between states. It's states getting together to agree to a template legislation in order to solve a national problem. And so we live with compacts. We just don't realize it. We take it for granted that we just don't think about compacts because we don't confront them day to day. But anytime you go from one state to the next with your driver's license, you are using a compact. Because you would expect that as you go from state to state, you should have to apply for a license in each state in order to drive across that state. But we don't have that. We've got a compact where states agree to abide by the license of agree to abide by the license obtained by the citizen in his or her home state. So that's a compact. Folks living on the Great Lakes, there are compacts that govern how the states share and use the Great Lakes. So compacts are not new. They've been with the country for hundreds of years and they're recognized constitutionally. So we realized that, hey, we may be able to solve this licensing problem with a compact. And so what the compact does, the compact basically says, in order for a physician to go through this process of obtaining an expedited to go through an expedited process to get a license, that physician would have to meet certain standards. So for a state to agree to this process, they would have to agree to the standards of this process. And so the standards of the process are as follows, that a physician going through this compact process has to have gone to an accredited medical school through the Liaison Committee of Medical Education, or the Commission on Osteopathic College Accreditation, or is a physician in the International Medical Education Directory, a medical school in the International Medical Education Directory. So there has to be an accredited medical education. The physician has to have successfully passed USMLE or COMLEX within 3 attempts. They have to have completed a graduate program of medical education accredited by the ACGME or the AOA. They have to have ABMS or AOA-BOS certification. They can't have any prior conviction or criminal activity. There can be no history of licensure actions. The DEA history has to be clean and no active investigations, and they must pass an FBI criminal background check. So basically, this bar to enter into this compact process is higher than your standard bar for getting a medical license. The other thing I'll say is the compact process is a choice. A physician who wants to get licensed in multiple states can always do it the old-fashioned way and go to each state capital or each state medical board and apply and get a license. But if you do it through the compact process, you have to meet these standards. And unfortunately, if you don't meet the standards, you can't take advantage of this particular process. And so what I like to explain to physicians, or when I talk about the compact, it's sort of an abstract idea for many people, but I liken it to the TSA at TSA PreCheck at the airport. If you think about it, those of you who have TSA PreCheck, what do? You go through a vetting process, and they do a background check. They make sure you're clean. They make sure you're above board. And once you've satisfied the government that you meet the qualifications for their compact process, then you get to go through the TSA PreCheck line, and you go through much faster than you go through the traditional line. But once you get through the line, you have no more or no fewer rights than any other passenger who comes through the security process at the airport. So this is an expedited process. It's really important to understand that, because some people think this is an expedited license. It's not an expedited license. It's the same license you'd have gotten had you applied through the traditional way. You're just getting it through an expedited process. Now, I only show this. This is just to show that when we sat down to look at how we would set this process up, we looked at every step along the way in licensing. And this is pretty much what we call a swim lane diagram, and we use this diagram to create the process that the physicians will actually go through online in order to obtain a license in this fashion. So again, the traditional process is that if you want to get multiple licenses in multiple states, you have to apply to each individual state medical board, and you go through, if you get 50 licenses in 50 states, you have to go through 50 different processes. And they're all slightly different. The questions they ask are slightly different, but that's the traditional method. Going through the compact process, you go online, you fill out an application, then that application is sent to the state that's going to vet it, right? So the state who's going to vet that application has to go through and make sure that you meet the qualifications. So when you apply online, you have to choose a state of principal license. Now, if you only have one license in a compact state and you want to get licensed in other compact states, then that's your only choice. Your state of principal license become the state in which you have your single license. And then that state vets your application to make sure you meet those qualifications. And once you meet those qualifications, then you can then get a license through this process. If you are a physician that has multiple licenses in multiple states, then you have to choose your state of principal license, and there's a process for deciding how you choose your state of principal license. So I'll walk you through the process. It's fairly straightforward. You go to the website. You have to choose a state of principal license, as I discussed, and you pay $700 for the application process. $300 goes to the state to cover the cost of having to vet your application. Now, the vetting process should be fairly quick because you already have a license in that state. So the state really already has your demographic data. It's already got your credentials, and your credentials are fixed, right? I mean, your medical school doesn't change. So a lot of the requirements are actually static. They don't change. But the state will have to do the criminal background check. The state will have to check to make sure that there have been no criminal convictions during the initial time of licensure and the time of application. The state will have to check to make sure there's no active investigation against you. And so there is some work the state will have to do to check those dynamic changes, if you will. So $300 goes to the state to do that and to cover and to help defray the costs for the state for the criminal background check. $400 goes to the Compact Commission to cover the costs of the process. Very early on, the states were clear that the states did not want to pay for this process. This process should be paid for entirely by users, and that's why there's a $700 fee. We don't know if this is the fee going forward because we had to pick a price, and this seemed reasonable to cover the costs early on, but this may go up depending on whether or not we are meeting our budget. So you've submitted your application to your state of principal license. Your state of principal license checks your eligibility requirements. And then once they've done that and they've realized that you've satisfied the requirements, you get a letter of qualification. If you will, this is your Willy Wonka golden ticket to the licenses in all the states. So your letter of qualification is the key piece. You need the letter of qualification in order to get the license. And then the compact legislation is very clear. It basically says if a compact state receives a letter of qualification and a fee, the state shall give the applicant a license. No ifs, ands, or buts. Now there's a caveat to this. So the state has to give the physician a license. Now some states require CME or some type of educational requirement prior to getting a license. Some states may want certain information or ask certain questions before they give the physician a license. The compact legislation is clear that the state has to give you the license, but the state can still retroactively ask you to provide the state with the information that they require. Or the state can ask you, after they give you the license, they can ask you to go back and do the mandatory training or HIV education, or some states have, you know, a legal education. So the states can still have you do that, and you still have to comply with the Medical Practice Act of that state. So just because you're getting a license through the compact process quickly does not mean that you're not obligated to give the states what they statutorily require. So the compact, and it's very clear in the compact legislation, the compact says that it is a process, but it is silent on the Medical Practice Act of the states. So you are still under the Medical Practice Act, and you still have to do what the states require you to do. And if you don't comply, then the states can clearly sanction you, which then affects your ability, which then affects your status in the compact. There's another piece of the compact legislation that's also really important and very valuable for many states in patient protection. In traditional complaint adjudication, by that I mean if a physician practices below standard and the patient complains to the states then do an investigation of that physician's practice. And in many cases, that investigation and ultimate adjudication can take years, months to years, right? And so states were very concerned about this because when states are in that investigation mode, many state laws prevent the medical board from sharing that information with other states. So if you have a physician who has 3 licenses, is practicing below standard in one state, that state then starts to do the investigation. That physician can then go to another state in which they have a license and start practicing before the investigation is complete. And that state where the physician moved won't have that information about the complaint in the other state. And so, and this frustrates states because states sometimes will get word that they have a licensee who's practicing below the standard, but because there hasn't been a formal complaint lodged in their state, it's hard for them to get that information. And states won't respond to subpoenas of other states. So from a patient protection standpoint, states, when we were developing the compact, states were clear that we have to have a better solution to this. So what happens through the compact, if there is a complaint lodged against a physician who has a license through the compact process, that state can share that investigatory information with other states. And then states can actually co-investigate the physician as well. So what this allows is a much better sharing of complaint and discipline history and information among the states. Now, if you're a physician who tends to be a little paranoid about how information is shared and you don't think it's good that states share your information for complaint history, then the compact is not for you. You'll just have to get your licenses each state at a time. But if you're a physician who practices above the minimum standard of care, then this really won't affect you. But it's only going to affect those folks where, if the standard of care or if there's a serious complaint or issue, then the states will be able to share that information. So there's a few other things that I wanted to discuss. So right out of the gate, we ran into this problem with the FBI. And I don't know if many of you have heard about it, but there's a lot of fake news, I don't know how better to say it, out there about what the FBI and the compact. And I was hearing things that the compact was illegal, and the FBI thought the compact, there was a problem with the compact, and the compact wouldn't go forward, and states were concerned about the compact. So the FBI issue is really a state-by-state issue, and it's a really obscure piece of legislation that I think it's worth spending a few minutes on. The compact requires that the eligibility requirement is of a criminal background check. Now, some states have been doing criminal background checks forever, and for those states, it wasn't an issue. But for states like my state, Minnesota, our state hadn't traditionally done criminal background checks at the medical board. So we had to set up a new process to do criminal background checks in Minnesota. And that process meant that we had to go to our criminal justice agency, because the criminal justice agency in each state interacts with the FBI. And so in order for the Board of Minnesota to be able to do this criminal background check, we have to have a law in place that requests this information from the FBI. The problem is this law has to be written almost perfect for the FBI to respect it. If it isn't written properly, then the FBI will not allow you access to their database. And that was the FBI issue. 4 states got letters saying that their enabling statute to access the FBI database wasn't written properly or wasn't vetted properly. And so several states had to go back. They fixed their enabling statute to allow them to access the FBI database, and they were able to then be a full participant in the Compact Commission. In Minnesota, we've made several changes to our statute. We've had to actually go back one more time. We believe that we know what we need to do now, and so hopefully next year, early on, we'll be able to correct our statute so that we'll be able to access the FBI database. Now, early on, when the Compact first got up and running, the FBI also had some other issues that they voiced in a letter, and they had some other objections to the Compact Commission. They were concerned that we were going to share their FBI information, which is a no-no. They thought we were going to build a database of physicians that contains their FBI information, which we weren't. They referred to the IMLCC as a private nonprofit, which is not true. We are a government agency. And they had some other objections too. So we, in the commission, passed some rules and made some changes to show the FBI that we understood where they were coming from, and also to show them that we want to be clear that we weren't doing the things that they thought we were doing. And recently we received a follow-up letter from the FBI, and that letter basically says, if you discover states that are experiencing issues, contact us. We're able to help. So we went from the FBI having concerns and having everybody sort of be up in arms about 6 or 7 months ago, to now the FBI understanding what we're trying to do. We're understanding how to use the FBI data. And so right now we're all clear that on what we need to do in order to make this work. And there really there aren't any issues now related to the FBI. So in getting the commission off the ground, our initial challenges, we weren't going to assess the states inside of the statute. We can go to inside of the compact statute. We can actually go to the states and assess them whatever we need financially in order to make this work. But we were clear that states wouldn't want to become part of this if they felt that this was going to be a very expensive process. And a lot of states and a lot of cynical individuals thought that this was going to be a very expensive, redundant overlay on the existing board structure, and this was just going to be a very expensive thing that was going to be an albatross. Well, it turns out that's not true. It's being paid for by the fees and grants, by the fees of the physicians, and we were able to obtain a grant from the federal government to the tune of $250,000 for 3 years, which is helping to fund the startup costs and to get this off the ground. So think of us as sort of a tech startup with very limited funding. So our initial results is that, like I said, we were able to get a $25,000 grant from the Federation of State Medical Boards early on. I talked about our 3-year grant from the federal government, the Health Resources and Services Administration, and the Federation of State Medical Boards is actually they hold the grant, but they are the grant goes through the Federation and comes to the Commission. We were frustrated early on because of the FBI issues. States couldn't fully participate, which deprived us of revenue right out of the gate, and so we certainly missed that. But now that that's rectified, we expect that we're going to be see increasing revenues. So our current challenges, when we first started this process, because we really didn't have millions of dollars to fund a study and then plan and then develop this really beautiful process that ran like a beautiful engine right out of the gate, because this is a government agency. That kind of money just doesn't exist. We sort of started this off as a proof of concept. What we found out in our first 6 months of going live is that it works, right? So what we need to do in the next step is to build a database for proactive reporting, which we're in the process of working on. We're doing cash accounting now. We're going to move to accrual accounting in the future, and we need to start standardizing processes within the states, which we believe will actually help to speed up the licensing process and make it more uniform. Because we're seeing that there is some variability in how quickly physicians have become licensed. Sometimes you can get licensed very quickly through this process within a week. Sometimes it may still take a month. I just wanted to really introduce you to the key staff. We only have 2 employees right now. Marshall Smith, our executive director, just came on board on October 1st, and he's the person who will be front and center in the organization going forward for contacts, giving talks, updating groups. And the other person is Wanda Bowling. She's our project manager. She's the person who helped us develop our IT infrastructure to date. So where are we now? I show this because I got this little puppy here. He was born in June, and in 6 months he went from this to this. And it was frightening because I was expecting a poodle a quarter the size of this beast. And the compact kind of did the same thing. We went from 0 to 22 states in about 6 months. And fortunately for us, it happened slowly because we were able to build and accommodate as states came on. If all 22 states came on at the same time, it would have really made it very difficult for us to develop this process in the way we have. The fact that people came on slowly allowed us to build and adapt to pass rules, and it's made us stronger as a result. So the blues is what you should focus on, the blue and the light blue. Those are the states that are actively participating. And you see it's primarily in the Midwest to West, with a smattering in the Northeast, and a few in the South, and the East. So we have 22 states that have passed the legislation. Of those 22 states, 18 states are issuing licenses. 12 states can act as states of principal license and do the vetting. 6 states are not acting as SPLs. So if you have so if you're a licensee in Colorado, Minnesota, Mississippi, Nevada, Washington, or Utah, you won't be able to apply through those states. Now, granted, if you applied through the other 12 states, you can get licenses in those states. You just can't apply through the process in those states. We've got 4 states that have delayed implementation: Maine, Pennsylvania, South Dakota, and Tennessee. And it's for a variety of reasons. Tennessee basically they passed the legislation but wanted to wait on the sidelines, and they wrote into the legislation that it won't become active until 2018. But I know they're undecided. South Dakota has several issues. Pennsylvania, I think the governor delayed implementation. I'm not sure why. And Maine is in the process. So for updates on the states that have joined and participating and their status, I would urge you to go to imlcc.org. The number of licensees to date, we've processed 157 applications we've processed 297 applications between April and September. And we're starting to see we're seeing growth, increasing growth month by month, and we've issued 384 licenses through the process. The data we can't report on, but in the future we'll be able to report on, is where those licensees are coming from, how many licenses per physician, some of the data that's really interesting. The problem is our current information system, that is a manual process, and as we transition to a ability to proactively report, then we'll be able to give you much more richer information as to who, what, where, why, how, etc. And with that, I'll end my talk, and I'll turn it back over to Jeff and be happy to take any questions from the group.
Perfect. Well, thank you, Dr. Thomas. One of the things we really love about the IMLC here at CompHealth is that in the end it makes it easier for physicians to make an impact across the country. In the past year, we've placed thousands of physicians across the U.S., and our licensing team has been helped by the Interstate Medical Licensure Compact. For example, we had a physician need in Minnesota, we had a physician in Wisconsin who started the process, and the typical process in Minnesota takes 7 weeks. The compact allowed us to get the doctor licensed in a mere 13 days from start to finish, which of course saved time and energy for the doctor and everyone else involved, but most importantly, it allowed the patients in Minnesota to have access to a physician more quickly. So I know our licensing team is very excited about giving doctors more freedom to work in the states they'd like to, and they'd be happy to answer more questions, but before we give you some contact information for them, let's go ahead and answer a few of your questions. So I will just read these, Dr. Thomas, from our attendees. So one question states, I live in a non-compact state. However, I do hold a license in a compact state. Will the compact apply to me?
Well, as I stated, there is an algorithm or rules regarding how you choose your state of principal license. Now, in order to choose a state of principal license, you have to have worked in that state at least 25%. So if you just have that license in that state and you're not actively practicing in that state, then you would not be able to use that state as a state of principal license.
Okay, thank you. Here's another question. Is the IMLC applicable for international graduates?
Well, only if they meet the qualification requirements. So an international medical graduate usually comes through So if an international medical graduate went to a medical school on the International Medical Education Directory, IMED, then they would meet the medical school requirements, with the understanding that the entry for international medical graduates into this country is through the graduate medical education system. So absolutely, if you can meet the requirements of the medical school and you complete a residency at an ACGME or AOA accredited residency, absolutely, you could certainly meet the qualifications provided you meet the other qualifications. So yeah, an international medical graduate is not excluded from this process automatically.
Perfect. Another question states, does your SPL have to be in a compact participating state, or can it be in any state?
No, the SPL has to be a compact state. Yeah.
Perfect. Another question is, if you are not eligible, do you get your $700 refund back?
No. Unfortunately, that's part of the process, and we've been trying to make it clear on the website, because this is all website driven, and so it's really critical for physicians to read the FAQs on the website. You really have to read them, because we're not giving refunds back if you don't meet, because that's the risk. If you believe you meet the qualifications and then you go through the process, then the state then has to go through and vet you. Well, that's time and energy that the state has to vet you, and if they vet you and you don't meet the qualifications, then there's no refund.
Okay. Is there plan for states that are not currently represented on the map?
Well, we're not advocacy, and this is where it gets a little confusing. So the Federation of State Medical Boards, every state, every member board in the country and the territories belong to the Federation of State Medical Boards. So the Federation of State Medical Boards works on behalf of state medical boards in advocacy at the federal level and at the state level. So the Federation of State Medical Boards has been doing the advocacy for states to pass the legislation. As the commission, our role and goal is purely to make this commission work, to make the licensing process as good as it possibly can be. Now, I'm always happy and have gone to states and given talks in a group such as Comp Health and other groups to talk about the process and how it works, and I'm very happy, and I've actually testified at in various states to help pass the legislation. But generally, those states have to pass the legislation. Typically, not uncommonly, it can be the state medical state medical association. I know in Minnesota, our medical association and several large managed care organizations supported the legislation and introduced the legislation. In other states, it might be the medical association. Some states it might be the physicians. In some states it might be large managed care organizations, insurance companies. So typically the sponsors of the legislation, there just has to be someone in the state who wants it to happen. So I would encourage anyone who wants this to pass in their state to try to cobble together constituents who would be interested in having this happen, and get a legislator involved to see the benefits and get it passed. The medical boards typically are not the place to have this introduced. And in fact, I'll tell you, and now that I'm coming off the commission, I'm immediate past chair, and I'll be off fully because I'm going off my state medical board, and my state medical board participation, when that ends, then I go off the commission. But there are some medical boards that don't necessarily support the legislation, but it's not the medical boards ultimately that decides whether or not the legislation is passed.
Okay, thank you. Another question we have is, can you clarify how the compact is different than the uniform application?
So the uniform application, so say if you're going to apply through all, just pick 50, you want to license in all 50 states, if you do the uniform application, you fill out that one application, and yes, that application does go to each medical board, but then each medical board will look at that application de novo. even though you fill out one application, 50 copies of that application go out to each individual medical board. And then the medical board looks at the application, and that process is their typical process. It could take several weeks to several months to get licensed. In the case of the compact, you fill out one application, one state does the vetting of that application, and all of the other states accept that that vetting was appropriate and will issue the license.
Perfect. Thank you. Once a license is obtained through the compact, does it have implications on licensure renewal?
So the statute requires that license renewal occurs through the compact, and this is where this is where we're going to have to build a really robust tech infrastructure in the future, because states have varying cycles for renewing their license. Some states it's every 2 years, some states it's every year, some states it's every 3 years, and renewal comes with, sometimes renewal comes with a questionnaire, sometimes renewal comes with bells and whistles that the state requires. And so since the renewals are going to be coming through the compact is going to need to develop a robust system in order to be able to alert the physician that to come through the compact and to do everything through the compact. The idea was that we were trying to make it as easy as possible for the physician to not have to deal with multiple licensing boards, but instead just deal with the one compact. But the renewal cycle piece is going to be, we're in the process of figuring that out, but that's yes, you're going to have to go through the commission for the renewal.
Okay, great, thank you. A number of questions are coming in, so I want to thank everybody for your questions. We're going to see if we can get to a few more. Dr. Thomas, can a physician apply for more than one license at a time through the compact?
Yeah, so what I didn't show was what happens when you have a LOQ. So what happens is you go to the website, pay your fee, fill out an application, and then you wait. Then you're emailed, hey, you have an LOQ. So then you go back to the website, and there's just a list, there's a menu of the states and their fees. You check the state you want, and you check the number of states you want, and then they total the licensing fees at the bottom, and then you pay for those, you pay the licensing fees, and you get your licenses. So that's it. You just, instead of having to go to each state by state medical board, you go online and you check the box. It's a checkbox. You check the states you want. The fees are tallied at the bottom, and you pay that. So there is some confusion too. People say, well, I thought I already paid my $700. No, the $700 is the application fee. You still have to pay the fee for the license in each state. And that fee is the same whether you get it through this process or through the traditional process. So then I've heard physicians say, well, geez, that's $700. I can get it. Well, then what's the point of paying $700 if I can get it for free? You can get it. You don't. It's true. You can get your license. You can pay your licensing fee. But the point of the $700 is that it's an expedited process. And theoretically, you can get, today, you can get 18 licenses through one application within possibly a few weeks. So if it's not worth it to you to do that, then this process isn't for you.
Perfect. We'll just do a couple more questions. Is there an expiration on your compact letter?
Good question. It's 365 days. It's a year.
Okay.
So yeah, you have a year in order to choose. If you come back on day 366, you'll have to pay another $700. And I'll add to that because there's probably a question about MOC. So if you, let's say you had let your certification lapse and you wanted to apply through the process. Well, you said, well, then I'm going to go ahead and I'm going to recertify my MOC just so I can go through this process. Well, you can do that. And if perchance on day 366, and I'm being theoretical here, you let your MOC lapse, nothing changes. You just have to be certified at the time of application. If your certification lapses after you get your licenses, there's no impact on your licenses. It's just that when you're going through the process, you've got to meet that MOC qualification.
Perfect, perfect. Well, thank you. Thank you, Dr. Thomas. That's about all the time we have today to answer your questions. But if you'd like additional information, or if we didn't get a chance to answer your question, there's some contact information here on the screen that you can reach out to us through email, and we will do our best to answer the question or reach out to Dr. Thomas to get assistance in answering the question. Dr. Thomas, we really want to thank you so much for taking the time out of your busy day to go through the compact with us. We hope everybody on the call enjoyed the presentation. So I just want to say to everybody, thank you for your time today. Have a happy holiday season and a great rest of the day. Thank you.
Thank you.